Browner.
Hi, thank you for showing up in this virtual world. That's the first time I'm doing this presentation virtually. So normally I say, please feel free to interrupt me anytime, but it's a little bit more challenging in this day and age. So I'm going to go through, as they said, submit the questions and I will get to as many as possible. I'm going to leave adequate time at the end for us to chat any spontaneous questions that come up or anything that tickles your brain while I'm talking. We'll go through them. What I'd like to talk about tonight is common pediatric emergencies and give you some toolkits to use to figure out what can be managed at home and what needs to come into the emergency department. What should you be bringing to us to see? When do you need to come and see us? So without further ado, let's get this going. So quo vadis, where are we going? So we're going to talk about a few areas. Very common complaints of patients coming to the emergency department: fevers, abdominal pain, respiratory illnesses, orthopedic injuries, cuts and wounds, and headaches. So let's start off with fevers. That's an old school mercury thermometer. I don't think anybody really owns those anymore. We all have these little digital ones, but the sentiment is the same. The old adage was, you feed a cold, you starve a fever. No, you starve a fever, you feed a cold. Fever is defined as a core body temperature of 38 degrees Celsius or 100.4 degrees Fahrenheit. But in and of itself, a fever is not an illness. It's actually a normal, natural, healthy response to the body to an infection or an insult. It helps the body mount a defense and mount its inflammatory response to start the healing process. Fevers are one of the most common reasons for ER visits. I worked the last 2 nights, and especially in the day and age of COVID, fever is prevalent with patients coming to see us every day, all day. But as I said, it's a normal response to infection. Our white blood cells are better at their jobs and want the temperature higher, or they're better at the jobs when the temperature's higher, and they intentionally ask the brain to raise the thermostat. It helps them fight any infection, whether it be a viral or bacterial or fungal. Normal core body temperature by textbook, we talk about being 98.6 degrees Fahrenheit or 37 degrees Celsius. But this varies throughout the day. And it can be a degree or so more or less than 98.6 or 37 degrees centigrade. It's typically lower in the morning, higher at night, and even newer literature is saying that the average human core body temperature is not exactly 98.6. So, sorry, hit the button. Too many buttons. And the thing is, it's less important to me what the number is, as opposed to what the child is doing with the fever. And how has the fever been progressing over the last few days? Is it going up each day? Is it going down? Is it staying steady? Those are key factors to us, as opposed to a specific degree. Reasons to come to the emergency room when there's a fever: any infant less than 3 months of age. First month of age, if you have a child in the first month of age and they have a fever, they are going to be admitted to the hospital. It is a very specific population that we're concerned about because they don't have the immune response developed to fight infections. Infections can spread rapidly throughout the body in those age groups, and they don't have vaccines to help them fight off infections. As each month goes by, their ability to fight infections and their risk for having serious bacterial infections decreases. But still, in the first 3 months, we are very concerned about those kids, and those kids are almost, in the first 2 months, almost universally sent to the ER. And generally 2 or 3 months of age are typically sent to the ER for an evaluation. Any fever when there's a convulsion or a seizure is something we want to know about. And it doesn't mean there's necessarily anything dangerous going on. There is a very common complaint that happens in kids 6 to 36 months of age called febrile seizures, where they will have a seizure induced by a fever, and treating the fever would not have prevented that, and giving all the appropriate medicines in the world would not stop it from occurring. It would occur no matter what. But it's something we need to evaluate to make sure there's nothing else going on, and it's just a simple febrile seizure that can be managed at home. Any fevers with mental status changes, strange behaviors, altered speech are of concern to us. Fevers with severe headaches or fevers with stiff necks we want to know about. Now, it's extremely common to have your head hurt when you have a fever. Anybody who's had COVID or any fever, for whether it be strep, flu, any other virus, it's not uncommon to have a headache. But there's a difference between like, yeah, my head hurts versus this is a severe debilitating headache. Same thing goes for stiff neck. You're going to be achy, sore with a lot of infections when you have fevers. But when your neck is stiff, it's a little bit different, and we want to evaluate those patients in the ER. Anytime there's a fever with difficulty breathing, we also should know we should be evaluating those patients in the ER. And again, kids will breathe faster when they have a fever because they need to have movement of oxygen in and carbon dioxide out, and it's going to be increased to help create the energy for the fever. So we expect some increased respiratory rate and the heart rate for kids with fevers. But when they're having difficulty breathing with the fever, that's a different story. Fevers with severe abdominal pain, that's something we want to know about. Again, it's not uncommon to have a bellyache when you have a fever. Strep throat, a very, very common symptom of strep throat is abdominal discomfort. We frequently see you have abdominal discomfort, headache, and sore throat with strep throat. There's a difference between, yeah, my belly hurts versus this really is severe abdominal pain. Fevers with the child who is limping or does not use one of their limbs is of concern to us. Any child that cries constantly, even if the fever goes away, they are inconsolable. They're just not acting like their normal selves. That's a child I want to know about. Fevers with particular rashes, and I'm going to pop them up for a second, are very important to us. Now, lots of things cause rashes, and in the ER, we categorize kind of generally rashes into the scary rashes and the non-scary rashes, or dangerous and not dangerous. Rashes that we can be concerned about are something like this, that look PETECHIAE, with little burst blood vessels in the skin, and we touch it, the color doesn't go away. Why is it not turning? There we go. Or a fever that looks like this. We have these kind of bruises on the legs. Those are rashes we want to know about when you have a fever with a rash like that. Other ones, like chickenpox, people don't see very much anymore. It was an extremely common rash in children and was very distinct. And nowadays, they often get sent to the ER for evaluation and testing, but they generally do okay. And then any kid that just looks sick with their fever, that's when we want to know about. Oh, hang on, I'm going to cough. All right. Sorry about that. Here we go. So, abdominal pain. The ouch, my stomach hurts. So, let's look at what's inside your abdomen. It is a massive amount of tissue. You have stomach. You have your intestines. All of this is small intestine. It comes around to the large intestine, round, down. You have your bladder, which sits all the way down at the bottom. Kidneys sit kind of behind on each side here. Liver sits up here. There's the gallbladder. Pancreas would sit generally in this space here. Spleen is back here. You see a little kidney picking out there. The appendix sits all the way down here. You have your adrenal glands on top of the kidneys, and in females, you have your uterus and ovaries that sit right down here. All of that in this compact little space between the diaphragm and the pelvis. A lot of structures that many things that can cause pain. Some that are concerning, some that need emergent evaluation, and some that are not concerning and can be managed at home. So as I said, half a dozen solid organs, 22 feet of small intestine, about 5 feet of large bowel, all in a tiny, compact little space. And by the way, there's this outside of everything here, there's a nice abdominal muscle wall that keeps everything in. That can get strains and injuries. So when should we be concerned about abdominal pain? Pain that lasts consistently for 24 hours is not getting better. We want to know about those. In all children, pain in the right lower abdomen is of concern. That's where the appendix lives. In young women, especially as they get older, you worry about ovarian issues, and that can be on the right or the left. Vomiting lasting more than 24 hours, green material or blood in the vomit, that is something that we want to know about and needs to be evaluated in the ER. There's blood in the stool, they're pooping blood, that is of significant concern as well. Belly pain and fevers are, as we said, of concern. That can go with a lot of things: appendicitis, strep throat, gastroenteritis. It's just simple vomiting and diarrhea illness, but those can be tough to tease out. Groin pain, when belly pain is also associated with groin pain, we want to know about it because there's a phenomenon in the body called referred pain, that you can have pain in one area that actually is related to another area. So in young boys, pain in the testicles can actually be lower abdominal pain. It happened to colleagues of mine in fellowship where a kid came in with lower belly pain, and it actually turned out that he had a testicular torsion, a testicular injury, and not appendicitis or any abdominal issue. Abdominal pain that's associated with urinary problems. The kid who can't pee for many hours, that's of concern. Abdominal pain and rash is kind of like the one I showed you before. That purpura rash is something we want to know about. And again, the common catch-all, the kid who just looks ill. They have this belly pain and they just don't look right. They look sick. They're not acting like their normal self. Those are of concern to us. Reasons for abdominal pain are actually very common. There are many common reasons and simple ones. Gastroenteritis, a vomiting and diarrhea illness. Springtime is the season of vomiting and diarrhea illnesses. It's been running through the community. It's kind of tapered off, but March into April, it was very, very active. Then we have non-specific abdominal pain where you don't have a great answer for it. That the abdominal pain occurs, but the kids manage it and they do okay. Viral illnesses are very common causes of abdominal pain. Constipation is a very common cause of abdominal pain. We get plenty of kids who they need to poop. And we're happy to help them. We're happy to oblige. Sometimes to the nurse's chagrin, but we do it and it comes out with great success and the kids do much better. Urinary tract infections are a common cause of abdominal pain. But then we start to get other areas. I spoke many times before, pharyngitis, strep throat, any kind of throat infection, mononucleosis. Your skin get a little bit, you can get liver inflammation with mononucleosis, Epstein-Barr virus, and it's not uncommon to have belly pain with that. Appendicitis is, depending as you get into like the 4-year-old age group and up, it's the most common surgical emergency that we see in children, abdominal surgical emergencies. And so we get a lot of those every year. Asthma, and it seems weird, but can cause abdominal pain. Kids who are having difficulty breathing, working hard to breathe, they're using a lot of their abdominal musculature. Ear infections, you get a few, for some reason, sometimes there's just a combination of irritation, just the kids don't feel well, it could be part of the fever, but you'll get abdominal pain with that. And then pneumonia is a very common cause of abdominal pain. Oftentimes when the pneumonia sits in the lower part of the lungs, it irritates the diaphragm, causes inflammation, it makes the belly feel bad. And we get several of those every year where we have a kid who comes in with seemingly all of the signs and symptoms of appendicitis, and it turns out when we get the CAT scan, they have pneumonia. And that does happen. Abdominal pain in infancy, so we're talking those young kids under a year of age. Vomiting and diarrhea illness, gastroenteritis. As they kind of get up into 2 years of, you get something called intussusception, which is when you can get something called and the volvulus is, malrotation is the not setting right. And then the volvulus is when it twists and cuts up its blood supply, and that can be a very dangerous way. Incarcerated hernias, so there's a little bulge that just you can't push in. There's a defect in the abdominal wall. Something called Hirschsprung's disease. Children who have difficulty pooping from the time they're born. There's a part of the colon at the rectum that doesn't get its proper nerve complement, and it doesn't open properly, relax properly, and they can get backed up, and it's a surgical complaint. Something called necrotizing enterocolitis, more of a NICU concern. Get a couple of full-term babies, but something more we see in NICU. Perforations of the bowel, and then just colic. Colic is an extremely common cause of abdominal pain in little babies. Kind of peaks at 12 weeks of age, and it gets better. It's very scary to families. It's very frustrating to families. It causes a lot of sleepless nights and a lot of stress, but it is generally extremely benign. As you get older into childhood, some of the things you're going to notice are the same and some are different. We see some gastroenteritis, the catch-all vomiting and diarrhea illness, typically viral. Appendicitis starts to rear its head as you kind of get into childhood after 3-4 years of age. Pancreatitis as you get a little older in childhood, where the pancreas gets inflamed. It can be due to viruses, it can be due to a gallstone as you get a little bit older. And there's just some cases that are just, we don't have a great answer for, but it happens. HSP stands for Henoch-Schönlein purpura. It's an auto-inflammatory response that occurs. You get these bruising-looking purpura that we talked about earlier, those pictures. And what happens with that is you can get some of that similar type of rash that you see on the skin, but actually happens in the intestines, can cause abdominal discomfort. Hemolytic uremic syndrome is an issue that goes along when you have been exposed to certain bacteria like certain E. coli strains that cause vomiting and diarrhea illnesses can cause problems with the kidneys and liver and cause belly pain. As kids get older, we actually start to see in childhood ulcers. They do occur and can be very painful. Constipation is, as I said, an extremely common complaint in the ER. We have several kids every week that get enemas and they do much better. Urinary tract infections will present with abdominal pain in childhood. Outside the first year of life, it's much more common in females. So we see it much more in women than we do in girls than we do in boys. And then there's something called functional abdominal pain that it doesn't have a great reason. It typically occurs on weekdays, or Sunday night through Friday afternoon, so kind of academic business days. It's good on the weekends, and it's a very concerning situation. The kids have a lot of discomfort, but it's typically a very benign process that we don't have to worry about. As you get into adolescence, gastroenteritis, shockingly, is still at the top of the list. That's the most common thing we see for belly pain. Then you get appendicitis. As you get into this age group, and there are children or teenagers who get involved in sexual activity, we can have ectopic pregnancies where the pregnancy does not enter into the uterus. It's outside the uterus and can be a surgical emergency. Something called pelvic inflammatory disease, when there's sexually transmitted infections that spread outside the uterus and into the abdomen in young women. And then testicular and ovarian torsions, similar ideas, just whether it occurs inside an ovarian or in the scrotum with the boy, but the testicular ovary twists on itself and cuts up a blood supply. That is a surgical emergency. Those are extremely painful, and we need to fix those very quickly in order to salvage the ovary or testicle. Inflammatory bowel disease, kind of late childhood into adolescence, starts to really present itself. Things like ulcerative colitis and Crohn's disease. These are chronic conditions, autoimmune issues, and are manageable, but need a lot of help and medication and dietary guidance from gastroenterologists. And then biliary disease, things like gallstones and gallbladder infections due to gallstones. We start seeing those late childhood into adolescence. The big key is though, and it goes with anything else, is when in doubt, check it out. If you're concerned, we're going to help out and we're there for you, and that's when you should bring it in. Respiratory emergencies, and I think I'm kind of staying right on time as I wanted to. All right. So when should you worry about respiratory issues? Now, a breathing rate that is faster than normal. And I put a caveat on that because, as I said earlier, fevers will increase your respiratory rate and heart rate. And that's expected, common, and okay. And if we correct for the fever and the breathing comes back normal, that's reassuring. That says that the kid was breathing fast because they just had increased metabolic demands. Their body needed more energy, more oxygen, more carbon dioxide out, and that's why they're breathing faster. But if they're not having a fever, or it just doesn't get better with that, then that's something of concern. Noisy breathing. There are lots of causes of noisy breathing. It could be anything from snoring to something called CROUP, which we see typically every winter, although there is a rush of CROUP going on right now. Lots of kids in the community. There's a couple of viral strains that are causing issues now. Infections that we don't see anymore due to vaccines, but something called epiglottitis can cause significant difficulty noisy breathing. But anytime there's really significant noisy breathing, especially outside the norm for what the child does, that's of concern. When you see increased work of breathing, when you can see their ribs or their collarbone outlines when they are breathing in, that's saying that they're really working hard. When their belly moves outward with every breath in, or their nostrils open up when the child breathes in, those are a concern. And the nostrils are actually one of my favorite things to look at with kids, because kids, especially young babies and the first couple of years of life, they really can't breathe deeper. What they can do is they can increase flow by increasing their nostril size. They can breathe faster and increase flow with nostrils. And the reason that it's basic physics, everything really comes back to math and physics, but the flow through a tube is exponentially related to your radius or diameter. So if you open your nostrils just a little bit, you exponentially increase the flow into the lungs. So in little babies, that's what they do. They start flaring their nostrils with every breath in. That's increasing the airflow in. So we watch that very, very closely. If you see that your child doing that, that's a child that's struggling. And if there's any discoloration that looks blue on the lips, the tongue, the body, that's of significant concern. So respiratory difficulty, when having difficulty breathing in fevers, they're getting lethargic. And a lot of people use the term lethargy, but in the medical sense, it's a kid who's really difficult to arouse. They're kind of really laying there, not doing anything. That's of concern versus the kid who's just kind of, I'm tired, but I'm doing okay. I need a little more rest. The inconsolable crankiness in a child who's having difficulty breathing is also of concern to us. And as I said, the catch-all of everything. The kid just looks ill. Your child doesn't look right to you. There is something wrong. Trust your instincts. Bring them in. So causes of respiratory emergencies. This year was actually a very off year for bronchiolitis. Many factors are going into that, and including schools being closed, people being homeschooled, daycares being closed, masking. So the most common cause of bronchiolitis is RSV, but we really had a significant drop off in bronchiolitis this past year. I expect next fall it'll be a banner year for bronchiolitis to come back, but we'll wait and see how things go. Bronchitis, generally not something I use as a diagnosis in kids, more the adult side, the adult physicians use those. Asthma is a very common cause of respiratory emergencies. Anybody who was listening who has had asthma can attest to the fact of what it feels like and how bad it can be. It's like breathing through a straw because the airways are inflamed and there's spasm in the muscle and shrinking them down, and it makes it very hard to breathe. Pneumonia can be a significant cause of a respiratory emergency because it's an infectious process. It takes up airspace in the lungs and kids can get pretty sick with that. CROUP, most kids with CROUP do very well. By the time they get to us, the scares that they gave their family with the way they were breathing are gone, mostly because CROUP is typically a winter illness, and one of the best treatments for CROUP is cold snap dry air. So when they go from the house into the car and into the hospital, that cold snap dry air really makes their throat feel better. Any noisy breathing they were doing is pretty much gone, and they just have a barking cough. But if that noisy breathing sticks in there, despite all being outside in the cold air, it's just not the right time of year, like we're seeing now. Sometimes those kids need a special breathing treatment, and we watch them for a little bit. And then anaphylaxis, severe allergic reactions, can cause significant respiratory emergencies, and something that we need to see immediately in the ER. So CROUP, as I talked to about before, most commonly caused by parainfluenza 1 and 3, 2 viral infections, not influenza, parainfluenza, different types. It causes a barking, seal-like cough. It is unmistakable. Once you hear it, you know it. Noisy breathing can occur. Kids get a hoarse voice. And the reason this occurs is that the infection really affects the voice box. The fancy term is acute obstructive laryngitis. If the voice box gets inflamed enough, you can have a high-pitched noise when breathing in called stridor. And it's different from asthma because asthma is more breathing out, wheezing, whereas stridor is inspiratory. It's going in that the airway kind of collapses down in the upper airway, and it makes this high-pitched noise. And if that continues, we give them a special breathing treatment. It generally gets better. A dose of steroids, and most kids do fine. And it's honestly, I like that one coming in the middle of the night because it's generally easily managed. Anaphylaxis, as we talked about, is a significant cause of respiratory illness and emergencies in children. You have an EpiPen, give them to your child. Your child's having a severe allergic reaction. Don't hesitate, give the EpiPen. If you're concerned, give the EpiPen. It is life-saving. It's EpiPen, AVQ, epinephrine auto-injector, whichever one it is, give the epinephrine. And then get them to the hospital immediately. Ambulance, if you're right across the street, run there, but get them to us because they will need monitoring and further treatment, not just epinephrine. And if you don't have an epinephrine, we have to give it to you. Respiratory stress should always be evaluated urgently and emergently. If you see a child struggling to breathe, they're working hard. Their ribs are sticking out every time they take a breath. Their head is bobbing up and down. Their nostrils are looking blue. They're just not acting right. They look extremely tired. Bring them in. That's a kid we need to be seeing immediately to make them better. And now we're into orthopedic emergencies, and it is the season of orthopedic, although it never really feels like it stops. We are getting back into the swing of things. Every kid, it seems like they've gone 110% to make up for all the activities they missed out on in the last year. So we have seen every spring we see a large number of orthopedic emergencies, and this spring is no exception. We've had lots of broken bones coming in through the ER and lots of kids getting casts and splints and all. So let's talk about those. Now, lots of injuries occur when kids play. My son frequently complains, oh, this hurts, that hurts, but he still plays. Those are I'm less concerned about. But if you see an obvious deformity, the kid needs to come in. The bone, it looks like they have two wrists, or there's a curve where there wasn't the curve. the foot's pointing in the wrong direction, they need to come to us. And depending on how bad it is, they may actually need immobilization by professional trainers, emergency medical technicians, paramedics before they're transferred to us. The bone is out of place. There's an open wound associated with the area that is thought to be broken. So they're like, oh, it hurts right here in this area, and there's a lot of swelling, and you see there's bleeding going on there. Then we need to know about that. Severe pain. They cannot use the extremity. Numbness, tingling, or weakness to the injured bone. The extremities cool or pale. That's stuff that needs to come in and be cared for promptly so that we can salvage the limb. We have lots of time to do it, but we want to do it promptly to make sure we get quick recovery and pain relief for the children. So a couple of years ago, we had the hoverboards. I wanted this just kind of gets into what how injuries can occur, but just if you look at a little video of this. Oh, my dog. And here he's going to about take a spill. And there he goes. And we see those all the time. People take spills, and it's just that easy to injure something. So little injuries can occur from, or big injuries can occur from little things that you wouldn't expect. We have plenty of kids, whenever they're out, make sure they have the bike helmets on. They should be wearing pads when they're doing certain like skateboarding activities. All these things can prevent significant injuries, but if it doesn't, we're there to help. We have a full complement of nurses, ER physicians, and orthopedists, pediatric orthopedists that will help fix any injury that we need to fix in a prompt and timely fashion. But always be aware of the dangling limb or the bone that has more curves in it than it used to. Okay. Do you stitch it? Do you put a first aid kit Band-Aid on it? Antibiotic ointment? So this first one, it's a scrape. It's kind of not the best picture, but it looks like generally an abrasion. If it's just the superficial layer of the skin and there's no major edges to it that you can pull back together, it's okay to Band-Aid. Put a Band-Aid on it. Clean it off. Put some antibiotic ointment on it. Put a Band-Aid on it. Change it a couple times a day, and do the antibiotic ointment for a few days. However, this wound, if you notice, it kind of has a nice gap in it. You can definitely fit more than a grain of rice in there. That's one that needs to be stitched up. And anything that needs stitches, that's something that have to come to the emergency department. It's better handled in the emergency department. We have a little bit more resources that other facilities may not have. And if it needs more repair than an emergency physician can handle, we have the backup and the resources to do what we need to do. Tongue wounds, sorry if I gross some people out, tongue wounds, not all tongue wounds actually need repair. Wounds that are less than an inch in the middle of the tongue will typically heal well. The ones we worry about for tongues, through and through wounds, if it forks the tongue more than an inch in length, that's ones we need to worry. It's one we need to stitch up. And they can be a challenge to stitch up depending on the age of the child. We sometimes have to sedate them because nobody really likes sticking their tongue out and having a piece of needle and thread going through it. And so it needs special help in the ER to get those tongue boo-boos injuries fixed. So any tongue injuries we really want to see in the ER as well. Things like this, though, this is road rash. Somebody looked like this person fell biking. I'll say it looks like there's some concrete or gravel out there. That's okay to clean up. I think that that's manageable at home. I have utmost confidence in all the parents that I've come across that wash it off, clean it off, and move on to let the kid play and get them back to their activities. And that's totally fine, and let that be. So why suture a wound? So we suture wounds, and suture stitches, they mean the same thing. We just spend a lot of time and money in medical school to make ourselves sound important. So we have to use the fancy words. So suturing wounds, we want to control the bleeding. That's the biggest thing. We don't want it to continuously bleed. It's aside from ruining clothing, you don't want to lose your blood. Closing the wound with stitches helps it promote healing. It discourages infection. Your number one barrier to infection, your number one immune or defense against infection is your skin. As soon as you open the skin, bacteria can get in and start growing and you get infections. And then finally, to many parents, big importance, reduce scarring. You don't want to have your kid have a scar. And so the quicker you close a wound, the less of a chance they're going to have scarring. Everybody scars to some degree, and the younger you are, the better you heal, the less you'll see it. But if you leave a wound open and don't repair it, you have a higher risk of having scarring that is significant and will be noticeable. So there's many different types of wounds. There's lacerations, which technically is a blunt force injury where you hit it on something, the skin tears. It's not a clean one like an incision would be if you cut with a knife. There's puncture wounds, like if you step on a nail. There's avulsions where a piece of skin gets pulled off. And there's abrasions where kind of like that picture I showed you with scrapes up on the leg and all. And we see all different types of wounds. Kids coming off bikes or rollerblades, skateboards, and they kind of tumble and they have some wounds that are abrasions, some avulsions, some lacerations, and then we have to clean them up and see which ones need what kind of treatment. So do I need sutures or stitches? Lacerations, punctures, and incisions are generally all suturable wounds. Avulsions that still have a flap of skin can be sutured. It depends on if we still have a flap of skin that we can use. Sometimes we actually have to, depending on where the wound is and what skin has been avulsed, we actually have to kind of reshape the wound, and we might have to have a plastic surgeon come in and do that, or kind of clean up the edge of the wound. We can do it to recreate a proper laying of the skin so that it'll look good. So the things we want to consider when you're wondering, do you need to repair these wounds or not, is do we see fatty tissue? And fatty tissue with these kind of, they look like spheres or oblate spheroids, little yellow spongy things. That's subcutaneous fat tissue. We're seeing that. That says it's a pretty decent depth of a wound and it needs to be repaired. Is it really wide and gaping? The edges are pretty far apart. That's a wound that will be stitching. And then wounds in high tension areas are better off being sutured. Certain areas of the face, joint surfaces. The reason for that is that the more, every time that wound starts to heal and close, as soon as you bend that structure, put tension on the wound, it'll open back up and it'll scar, and it'll increase the risk of scarring, increase the risk of infection, and you'll just bleed more. So we want to close any kind of high tension wounds. Now we'll move on to headaches. Poor kid's got a little headache. Extremely common in children, and a wide range of causes with many levels of severity. Headache medicine is a complicated field because it's not like I can do a swab and say, oh, you have a migraine, you have a tension headache, like I can with strep throat or viruses with a nose swab. We rely on descriptions of what the patient's experiencing and other things we're finding on vital signs, physical exam features. Common triggers to headaches: too little sleep. And that's, as I can attest to my kids being in multiple activities, it happens that they are running themselves ragged, parents running themselves ragged, and gives you headaches. You are tired and you get a headache. Skipping meals is a common cause of headaches. Kids get the hunger headache. I know I get it. I know plenty of colleagues of mine get it. I know one of my kids gets a little hangry. Long bus or car trips, kids can present with headaches. Prolonged TV or computer use can cause headaches. Very loud music or any very loud noise, that decibel level can cause significant headaches and discomfort. Stress is an extremely common cause. I'm sure that all of us have experienced it, but get the stress headaches. Strong odors and like perfumes, smokes, or any kind of fumes can give significant headaches. Dietary triggers: too much caffeine consumption, or conversely, an interesting caffeine withdrawal. And then more interestingly, sometimes caffeine can be a treatment. If anybody here has migraines, if you look at the ingredients of an Excedrin migraine, one of the ingredients is caffeine. Caffeine actually is a very important tool that we can use for people who are having migraine headaches, because it helps correct what's going on with the blood vessels in the head that's causing the migraine headache. Certain foods like alcohols, cheeses, nuts, fatty foods, hot dogs, foods with MSG have been thought to cause headaches. The MSG thing has been coming under question, but foods, suffice to say, can cause headaches, and it's not uncommon. Hormone change in the hormone levels, menstruation can come with headaches. Head injuries and trauma are an extremely common cause of headaches. Kids with concussions will often complain of headaches, and that's one of the signs we have that that they're having a concussion. Depending on how severe the headache is, we get more concerned that it's more than just a concussion, and needs some more investigation. Dehydration: you're feeling low on fluids, as it happens in this time of year when kids go outside and they're playing sports and not hydrating adequately in very hot days. Like today, it's about 80-something degrees with a heat index in the 90s. Kids need to be hydrating well to keep themselves from getting these headaches. Certain medications can cause headaches. A very common cause of headaches in kids and one of the things that pediatricians will often check for when a kid complains of these persistent headaches is visual changes, vision problems. You know, they can't see the whiteboard or the computer screen. Those are things that we need to be addressed. Certain infections like ear infections, flu, throat infections, sinus infections, and let's throw COVID in there. COVID will cause significant headaches. Lyme disease, meningitis, and encephalitis. Those are the more concerning, especially meningitis and encephalitis, concerning causes of headaches that need to be addressed promptly to save some, especially meningitis, so that we can initiate life-saving treatments. Tension headaches, it is common in children. It does occur. They feel stress. We all feel stress. So they can get tension headaches. Migraines are difficult to diagnose in young kids. They do occur. As they get older, they're better at describing it, but we do get plenty of children who get migraine headaches as you get into older childhood, kind of the 8, 9, 10-year of age range. That's when we start to see them rear their ugly heads. Cluster headaches kind of sit typically behind on one eye. Can actually make the eye very red. You can have some tearing a little bit as they get into kind of adolescent ages. And then injury-related headaches, traumatized brain like concussions, or if it's a significant injury, intracranial bleeding, brain swelling, or skull fractures can have significant and will have significant headaches typically. So when to worry? The headaches that make us concerned they happen once a month or more than they have kind of this regular pattern of headaches. They don't go away easily. You know, Tylenol, Motrin really don't make it better. Severe, painful, like this is the worst pain of my life headache. A kid who's got a headache and is truly lethargic, just laying there and not doing anything. Headache that makes you vomit. But more importantly, the headache that wakes the kid up between like in the middle of the night, like 1, 2, 3 in the morning, kids waking up with a headache and they're vomiting, or the upon waking up in the morning, they have a headache and it's really bad. Those progressive headaches that kind of occur every day and especially worsening headaches, those are red flags for us. And we always get very concerned about kids who have headaches in the middle of the night when they're sleeping. Traumatic headaches, the kid who had a significant head injury and they're really complaining of a persistent headache, I want to see. Kid who has a headache and a seizure. It happens a few times a year. We get a couple kids that come in that have these headaches and they have a seizure and something significant happened inside their head, and we need to address it quickly and promptly, sometimes with surgical interventions. Numbness or tingling or weakness with a headache is of concern. Kids who have a headache and they start to get clumsy. They're just not coordinating right. Difficulty walking or standing is of concern for us. Or kids who have a headache and they just all of a sudden they find it difficult to find the right word. They're not able to speak properly. Their language is off. That is a significant concern. That's different from the normal that the child is doing. Headaches when you have, now, as I said, it's not uncommon to have a fever or sign of infection with a headache, but it's, you know, I got a cough, congestion, my nose headache versus I've got a headache and I just got a fever and I look sick. That's a concern. Again, that neck pain or stiffness with a headache makes us concerned about things like meningitis. A change in the kid's personality with a headache, that's of concern that we want to know about. They're just not acting like a normal person. They're a completely different person now. Headaches that cause visual changes. And then they have a headache and they're drinking or urinating excessively, of significant concern, and kids that need to come into the ER. So shockingly, again, when in doubt, check it out. If you're concerned, bring the kid in. If it's a scary headache to you, we need to address it. Poisons and medications, your number one resource. If you're concerned that there may have been exposure to a toxin, kid got into a medication, a cleaning supply, call poison control. It is the same number throughout the entire United States. Whatever state you're in, it will route you to the local poison control center, but it's 1-800-222-1222. It's an easy number to remember, 1-800-222-1222. The New Jersey main office is, as it's there, 973-972-9280. Should still be accurate. And then you follow the prompts to get to poison control. Right now, they're actually the poison control and COVID questionnaire hotline. If there's ever a concern that a kid had ingested a medication, cleaner, poison, toxin, anything, bring it with you. We need to know not only what you think they had, but also I want to know what other medications, cleaning supplies were in the area so that we can really get an idea of what could have been the exposure, what could have been the things that the kid was taking that led to the problem they have, so that we know how to properly manage it. Medications, poisons, you want to keep them out of reach of children and locked up. One of my favorite books ever, Hitchhiker's Guide to the Galaxy, has a great line. It says, those who design things to be foolproof generally underestimate the ingenuity of complete fools. And the same thing goes for kids. They will find it. Childproof caps don't exist, even though they're good ones. I mean, kids find their way into these things. So anytime you have kids in the house, you need to lock away all your medications, keep them in place kids can't get, put locks on the cabinets that have all the cleaning supplies, anything that could be a toxin. If you think they cannot reach it, they probably can. My children climb on the counters, they find their way into places. We have to keep it very close eye and locks on what we have in the house. So I've hit my 45-ish minute mark, which is what we want to try to set to. So medicine is the only profession that labors incessantly to destroy the reasons for its existence. And that's true. Nothing would give us greater joy in medicine than to get rid of the need for medicine. Any pediatric, especially pediatrician, would tell you, like, there are many things in kids that we just wish we didn't have to have a field of medicine for. A lot of these medical things that we talked about, we still need to have interventions for, but with prevention and education, we can do better. And yes, we will try to drive ourselves out of business and happily make everybody healthy forever. And that's what I have. So if anybody has any questions, I'm eager to listen and answer.
Awesome. All right. So we do have one question. Can you tell us a little bit about the current COVID vaccine being made available to children, and should all of our children get it?
So right now, the COVID vaccine is approved to as young as 12 years of age. And they are currently in trials to go down to as young as 2 years of age, I believe. But that they're hoping to have that data released in the fall. I am a big proponent of vaccines. I make no qualms about it. It is something that I push in every lecture I've ever given. I have seen kids die from vaccine preventable illnesses, and I've seen kids survive because they were exposed but didn't get it because they had vaccines. So vaccines save lives. It's that ounce of prevention, pound of cure. And I've talked to many families. I've talked to many people about vaccines, and I listen, and I understand that people have their questions about it, and having a dialogue is important about it. The way these vaccines work, the technique is not a novel technology. It's been used in veterinary medicine before. It's actually not something that's like, oh, we came up with. They've been working on experimenting with this and getting ready to roll out in human populations in the last few years. And the coronavirus family of viruses was an area that we were already targeting. So this was kind of already in the pipeline in Moderna's stuff, and then Pfizer was working on it. They were working on it as well. The evidence is really amazingly positive. There was at one point there was this rumor going around, oh, could cause infertility. And one of the studies they were looking at with patients in the older populations for infertility was the only person that had infertility issues was in the placebo group, and there were many women in the treatment group that got pregnant. So the data so far is showing that at least as young as 12, it is safe, it's effective, it's going to open us up, it's going to let us travel. I didn't go to Disney last week with my kids because they would have to quarantine for 10 days when we got back, and I just didn't want to miss any more activities in school. That's the sole reason. I'm vaccinated. My wife's vaccinated. We actually both had COVID, but we both got vaccinated as well. My job needed me to have, they wanted me to have that, understandably so. So I say, if the data supports it, the data supports it. Now, we have to wait and see what the data says, but so far what we're finding is just a lot of positive information that it works. The numbers are down tremendously. You can actually, if you get, I think on Valley's website, and Danielle might be able to correct me if I'm wrong, but we have a daily curve of where our COVID cases are right now. Last night we had no new admissions. The vaccine's out there, vaccine's working. We're opening up, things are getting liberalized because the vaccine's out there. So I say, if the data says yes, and it's good, get the vaccine for your kids.
Awesome. And yes, last I heard, there were no cases in the hospital. So that's pretty exciting news.
Yeah.
All right. If any other questions want to come in, we're open to them. Otherwise, I'll start closing out. I did include a couple of links in our chat here for Thrive to join our Facebook group, and also to join our membership program, where you'll just get an email once a month about programs similar to this, targeted towards you. All right. So thank you so much, Dr. Browner. That was super informative. I know that I am much more relieved and can sleep easier with knowing my children don't need to come see you, I don't think.
And I will say, so not to plug us too much, but Valley is an interesting hidden gem to have a 24-hour, 7 days a week pediatric emergency department staffed by pediatric emergency medicine physicians in a community hospital is typically unheard of in the United States. You really only get that in academic facilities. So to have the pediatric emergency department that we have, they're staffed by people like me who I did a pediatrics residency and then subspecialty training in pediatric emergency medicine. And that's pretty much what we all are. We're specially trained to do this, and it's an extremely rare thing. So it's a nice thing for the community that we have access to what we have and the support resources that we have between our local physicians here, plus our affiliations with Sinai and all their subspecialty services that rotate out here, and we have them on call and they come in to see our patients all the time when we need them. That it really is a nice thing to have for the community. So we are there. We're 24 hours a day, 7 days a week. We're happy to help.